Currently, the U.S. Preventive Services Task Force recommends screening people between the age of 55 to 80 who have smoked 30 pack years or more and who have smoked within 15 years. So this is the criteria used based on age and pack years. However, we have evidence to suggest that a risk prediction model is actually more efficient in identifying people at high risk of lung cancer. So currently, the most accurate lung cancer risk prediction model is called the PLCO 2012 model that was developed by Dr. Martin Temamagi. So the model differs from the age and pack year criteria in that, in addition to using smoking criteria, the model also used 7 non-smoking criteria, such as body mass index, educational level that reflects the socio-economic status, a personal history of cancer, not lung cancer, but other cancers, a personal history of chronic obstructive pulmonary disease, and a family history of lung cancer. So using this prediction model in retrospective analysis, using data from Canada, US, Germany, and Australia, the model was found to be superior than age and pack year criteria. But we need to do a prospective comparative study to find out which selection criteria is better. So this is the basis for the international lung screen trial, where we enroll ever smokers in Australia, Canada, and UK, and Hong Kong. So we have 9 centers in 4 countries. So it's a multi-center, multi-country study. So we enroll people between the age of 55 to 80 who have ever smoked, that satisfy either the age and pack years criteria or the PLCO risk prediction model criteria with a lung cancer risk of 1.51% or more over 6 years. So the study enrolled almost 5,000 ever smokers, and what we found is the risk prediction model is significantly more sensitive than the age and pack year criteria. We find 18% more lung cancer screening the same number of people. On the other hand, if someone only meets the age and pack year criteria but negative for the PLCO criteria, only 0.3% of them would have lung cancer. So the PLCO model is way more efficient than age and pack years alone to find the people at risk of lung cancer who would benefit from screening. Another finding that we have is the one that are missed by age and pack years criteria alone. Most of them actually have early stage 1 or 2 lung cancer that are potentially curable. 82% of them have stage 1 or 2 lung cancer. So this is very important because we want to find people, not more people that would benefit from screening, but also more people with early stage lung cancer that are potentially curable by screening. So overscreening can be controlled by the use of a proper nodule management protocol. So another part of the international lung screen trial is to evaluate a risk-based nodule management protocol that we call the PanCan nodule management protocol, where we look at the individual based on risk. So for example, with someone have no nodule or nodule less than 1.5% lung cancer risk, they actually go to a biannual screening protocol. And it turned out 82% of people do not benefit from annual screening. They can safely go for biannual screening protocol. So then people with a slightly higher risk, between 1.5 to less than 6%, we charge them to an annual screening protocol. And then people with 6% to less than 30%, we do a repeat CT in 3 months. And people with higher risk, we charge them to a diagnostic pathway. So using a very strict criteria for management, we cut down over investigation substantially. So only a few percent of people will end up into a diagnostic pathway. So in our study, only 3% of people will go on to a diagnostic pathway. We hope they will change based on this result, and also now that with 2 large randomized clinical trials that show the benefit of screening, they will also change the strength of the recommendation for screening as well.